Welcome to the Deep Dive. Today we're diving into the incredible world of your kidneys, uncovering how these masterful organs, precisely manage the essential substances in your body. We're going beyond just filtration to explore the sophisticated transport of key solutes, things like urea, glucose, phosphates, calcium, and magnesium.
The really critical stuff.
Exactly, our mission.
Yeah.
To give you a clear, concise shortcut to truly understanding renal physiology, helping you grasp how your body maintains its delicate balance, and why this knowledge is so vital for future medical professionals.
It's truly a remarkable system. The kidney is far more than just a filter. It's an active dynamic regulator that constantly adjusts levels of substances in your blood.
Right.
We're going to break down these complex transport mechanisms from the big picture down to the step-by-step processes, and crucially, connect them to real-world clinical scenarios.
Good.
Think of this as getting the most important insights from your physiology texts, but, tailored for clarity and understanding.
All right, let's unpack this, starting with urea. Often seen as just a simple waste product, urea's journey through the kidney is anything but.
Not simple at all.
Your liver mostly produces it as the primary way to get rid of nitrogen from amino acids. While most of it leaves your body in urine, a tiny bit also exits via sweat and stool.
Yeah, minor rotes mostly.
Typically, your plasma urea levels are pretty low, and in the clinic, you'll see this measured as blood urea nitrogen, or BUN.
BUN, right.
For most healthy adults, a normal BUN is between, 7 to 18 milligrams per deciliter?
Yeah, roughly in that range, that's correct.
And here's where the kidney's unique approach begins. It freely filters urea at the glomerulus, but then it gets interesting.
It does, because the kidney both reabsorbs and secretes it back into the tubule.
Both.
Exactly. Ultimately, though, more urea is reabsorbed than secreted, meaning only about 40% of the filtered urea actually makes it out in your urine. That's at average flow rates, of course.
40%.
It's a very precise, constantly adjusted balancing act.
So how does this journey actually unfold step by step through the kidney's nephron?
Okay, so it begins in the proximal tubule. Initially, right at the start, urea's concentration inside the tubule is basically the same as in your blood.
Makes sense.
But as the proximal tubule rapidly reabsorbs water, and it reabsorbs a lot of water, the urea left behind in the tubule gets concentrated. This creates a powerful gradient that drives urea reabsorption. It essentially gets swept along with the fluid that's called solvent drag.
Okay.
Or it diffuses, across cell membranes or through the spaces between cells.
So the water pulling drives the urea out too?
Pretty much. The more water reabsorbed here, the more urea follows.
Okay, so it gets reabsorbed there.
Yeah.
But then you said it's secreted back and further down the line. That sounds a bit like recycling.
That's precisely it. And it's key for urine concentration. It's a bit counterintuitive, maybe.
Yeah.
In parts of the loop of Henle, particularly in those nephrons that dip deep into the kidney medulla, urea is secreted back into the tubule. It happens because the surrounding tissue in the kidney's inner medulla has a very high urea concentration. It's like a urea reservoir. This high concentration draws urea transporters like UTA2 facilitate this movement. This recycling is absolutely critical because it helps build up and maintain that high urea concentration in the medulla, which is essential for the kidney's ability to produce concentrated urine later on.
Setting the stage.
Exactly. The net result of all this filtration, reabsorption, and secretion is that often more urea is delivered to the collecting ducts, the later parts, than was initially filtered. It's kind of loaded up, ready for its final reabsorption step.
And what's the final stop for urea then? Where does that happen?
The inner medullary collecting duct, or IMCD. This is where urea has its last major reabsorption.
Okay.
This reabsorption happens right through the cells. It's transcellular, facilitated by specific transporters on both sides of the cell, especially one called UTA1 on the side facing the tubule lumen. And what's really crucial here is that arginine vasopressin, or AVP, probably known as antidiuretic hormone, ADH powerfully stimulates this UTA1 transporter.
The hormone connection.
Yes, when AVP is present, like when you're dehydrated, it boosts UTA1 activity. This allows more urea to move out of the tubule and contribute to that crucial medullary concentration gradient needed for water reabsorption.
That makes perfect sense. It all ties together. And speaking of urine flow, you mentioned earlier that urea transport hinges on concentration differences. So what does this tell us about, say, someone who's dehydrated?
Right. This brings us to a really important clinical point. When urine flow is low, like during dehydration, the kidney works very hard to reabsorb a lot of water.
To conserve fluid.
Exactly. Because so much water is reabsorbed, a lot more urea is also reabsorbed along with it. It just follows that concentration gradient. This causes urea to build up in the blood.
Okay.
And that leads to a rise in your BUN levels. Now, a clever trick here is comparing BUN to creatinine.
Creatinine, right? Another waste product.
Yes, and we use it to estimate kidney function. Crucially, creatinine clearance is largely unaffected by urine flow rate, unlike urea.
Ah.
So in dehydration, you see BUN levels rise, but creatinine doesn't rise nearly as much. This leads to an increased plasma BUN to creatinine ratio. Normally, it's around 10. If it's significantly higher, that gives us a strong indicator of dehydration, or what we call pre-renal azotemia.
That's a neat diagnostic clue.
It really is. And conversely, if someone has high urine flow, maybe they drank a lot of water, much more urea can be excreted. It's sometimes up to 70% of the filtered amount.
It's remarkable how the handling of a simple waste product offers such a clear diagnostic window. Now, let's shift gears entirely to glucose, the body's precious fuel.
Absolutely vital.
Normally, your fasting blood sugar is tightly regulated, between 70 to 100 milligrams per deciliter, mainly by insulin.
That's the range, yeah.
Your kidneys freely filter glucose, but thankfully they reabsorb almost every bit of it. Only trace amounts usually appear in your urine, which makes sense given how vital glucose is as an energy source.
Can't afford to lose it.
And this reabsorption primarily happens where? The proximal tubule again.
That's right. Almost all of it happens in the proximal tubule. Glucose reabsorption is a transcellular process. It moves from the tubule lumen into the cells, and then from the cell into the bloodstream.
How does it get into the cell?
Against its gradient, right?
Exactly. On the luminal side, facing the filtrate, a family of sodium-glucose cotransporters, or SGLTs, pulls glucose into the cell. This is uphill transport for glucose, moving against its concentration gradient.
Okay.
It's powered by the strong sodium gradient. Remember the sodium-potassium pump on the other side of the cell, the basolateral side?
Sodium out.
Right. It constantly keeps intracellular sodium low. This low sodium inside creates a steep gradient favoring sodium entry from the lumen. The SGLTs harness the energy of sodium moving down its gradient to pull glucose up its gradient. It's a classic example of secondary active transport.
So the sodium gradient pays the energy bill for glucose uptake.
Precisely.
So what happens when there's too much glucose? Like in diabetes, does the system get overwhelmed? This is where the glucose titration curve becomes essential. If you imagine a graph plotting glucose levels against reabsorption and excretion,
Okay.
the first key feature is the threshold. Glucose simply doesn't appear in your urine. You have zero excretion until your plasma glucose concentration exceeds a certain point. It's usually around 200 milligrams per deciliter, maybe a bit lower in some people.
The renal threshold.
Exactly. That's why glucose in the urine, or glucosuria, is a telltale sign of uncontrolled diabetes. The blood sugar is just too high for the kidneys to reclaim it all.
So it's not just a threshold. Does the system eventually get completely saturated?
Yes, exactly. That leads us to the second feature, saturation, or the maximum transport capacity, which we call TIM, transport maximum.
I got it.
As plasma glucose keeps rising, way past the threshold, the reabsorption rate eventually plateaus. It hits a ceiling, typically around 400 milligrams per minute. It's because the SGLT transporters, both the main types SGLT2 and SGLT1, simply become saturated. They're all working as fast as they can, but there's just too much glucose coming through. They can't physically reabsorb anymore, no matter how much is filtered.
Okay, saturated. And you mentioned a third feature.
Yes, the third feature is called splay. The reabsorption doesn't just abruptly hit its maximum TIM when the plasma level hits a certain point. Instead, it gradually curves and approaches the TIM.
Ah, like a rounded corner on the graph.
Exactly. This splay reflects the subtle differences between individual nephrons. Not all nephrons are identical, you know. Some might have slightly different filtration rates or slightly different numbers of transporters. So some nephrons start spilling glucose a bit earlier, others a bit later. The overall curve is the average of all of them.
Interesting heterogeneity. And how does all this affect glucose clearance? How much glucose is actually cleared from the blood?
Right. At normal glucose levels, below that threshold, glucose clearance is essentially zero because none is appearing in the urine.
Makes sense.
But once the threshold is crossed and glucose starts spilling into the urine, its clearance starts to increase. Now think about extremely high glucose loads way above the TIM.
Okay.
At that point, so much glucose is being filtered that the amount being reabsorbed, which is maxed out at TIM, becomes a relatively small fraction of the total amount excreted. So glucose clearance actually starts to approach the clearance of inulin.
Inulin, the substance we use to measure GFR.
The very same. Inulin is freely filtered, but neither reabsorbed nor secreted. So when glucose clearance approaches inulin clearance, it means glucose is essentially behaving like a substance that's only filtered because the reabsorption part is overwhelmed.
That's a neat way to think about it.
And here's the core principle, the take-home message. These four characteristics, threshold, saturation, splay, and clearance approaching GFR at high loads, aren't unique to glucose. They apply to many other precious solutes your kidney handles meticulously, like amino acids, phosphates, Krebs cycle intermediate.
That's a powerful general principle to keep in mind. Speaking of which, let's talk about amino acids, the body's essential building blocks.
They're also freely filtered, right?
Freely filtered, yes. But an impressive 98% or even more are normally reabsorbed, primarily by the proximal tubule.
Again, makes sense. Can't waste those.
Absolutely. This reabsorption is a complex transcellular process involving a whole host of different transporters on both the tubule-facing, apical, and blood-facing basolateral membranes. Many of these transporters are driven by the sodium gradient, much like glucose transport, though some use other ions like H+ or work via exchange mechanism.
A whole variety of
A wide variety, yeah. And because structurally similar amino acids often share the same carriers, you can get competitive inhibition. Meaning if you have a very high concentration of one type of amino acid, it might compete with structurally similar ones for binding sites on the transporter.
All right.
This can lead to incomplete reabsorption of the other amino acids.
While amino acid reabsorption also shows saturation kinetics, just like glucose, their TIM values, their maximum transport capacities, are generally lower than glucose's TIM.
What does that mean functionally?
It means that if plasma amino acid levels rise significantly, they tend to appear in the urine more readily than glucose would at a similar relative increase. This might actually be a protective mechanism helping your body prevent excessively high plasma concentrations of certain amino acids.
And I imagine there are clinical conditions tied to problems with these amino acid transporters.
Yeah.
Specific diseases.
Yes, absolutely. There are several genetic conditions called hyperaminoacidurias. Some are overflow types, where a high plasma level of one amino acid simply overwhelms its transporter's TIM, but others are due to defects in the transporters themselves.
Like what?
For example, Hartnup disease involves a defect in the apical transporter responsible for reabsorbing neutral amino acids. Another well-known one is cystinuria.
Cystinuria, kidney stones, right?
Exactly. That's caused by a defect in the transporter for cysteine and certain positively charged cationic amino acids. This leads to increased excretion of cysteine, which is unfortunately poorly soluble in urine, especially acidic urine, and it crystallizes out, forming kidney stones. These transporter defects really highlight how critical each specific transport pathway is.
Definitely shows the clinical relevance. What about larger organic molecules, like small proteins or peptides? Even though the glomeruli mostly restrict large proteins like albumin, some smaller ones must get through.
Indeed. Even though the filtration of large proteins is normally quite restricted, a small but significant amount, particularly smaller proteins and peptides, does get filtered daily, maybe a few grams of albumin even.
Okay.
And the kidney is remarkably efficient at reclaiming these. It reabsorbs an impressive 96% to 99% of this filtered protein load, again mainly in the proximal tubule.
How does it grab something that big? Not the same transporter, surely.
No, it's a different mechanism entirely. The primary way is called receptor-mediated endocytosis.
Endocytosis. Cell engulfing something.
Pretty much. Proximal tubule cells have special receptors on their apical surface, like megalin and cubolin, that bind to these filtered proteins. Once bound, the cell membrane invaginates and pinches off, forming vesicles containing the protein inside the cell.
All right.
These vesicles then fuse with lysosomes, the cell's recycling centers. Inside the lysosomes, enzymes break down the proteins into their constituent amino acids.
Ah, back to building blocks.
Exactly. Those amino acids are then transported out of the cell and back into the bloodstream.
So the protein itself doesn't get back into the blood, just its components.
Mostly, yes. This explains why significant protein in the urine, proteinuria, doesn't always mean there's damage to the glomerulus filter. It can also result from injury to the proximal tubule cells that prevents them from performing this endocytosis effectively.
That's an important distinction. The kidney really is a metabolic powerhouse. Now let's quickly touch on other energy-related molecules like carboxylates, lactate, pyruvate, citrate, things like that. Crucial for our energy metabolism.
Yes, absolutely. And normally, virtually all of the filtered load of these carboxylates is reabsorbed in the proximal tubule. Can't waste energy intermediates.
No.
They're primarily reabsorbed by specific sodium-dependent cotransporters, similar in principle to glucose and amino acids. There are distinct ones for monocarboxylates like lactate and for tetracarboxylates like citrate.
Okay. And is there a clinical connection here too?
There is. A key one is the appearance of ketone bodies like acetoacetate and beta-hydroxybutyrate in the urine during conditions like prolonged starvation or uncontrolled diabetes mellitus.
Ketonuria.
Right. This happens when your body's producing large amounts of ketone bodies as an alternative fuel source. Their plasma levels rise so high that they exceed the proximal tubule's maximum capacity for reabsorbing them, and they start spilling into the urine.
Another example of saturation. Speaking of efficient excretion this time, let's talk about p-aminohypryate, or PAH. This is a synthetic anion, right? Not something our body makes.
Correct, it's exogenous, but it's a fantastic tool used in physiology and clinical settings to measure renal plasma flow.
Why PAH?
Because the kidney is incredibly efficient at clearing it from the blood. At low plasma concentrations, nearly 90% of the PAH entering the kidney via the renal artery is removed and excreted in the urine in a single pass.
Wow, almost complete clearance. How?
It's achieved through a combination of filtration at the glomerulus and very active secretion by the proximal tubule cells, mainly in the later parts, the S3 segment.
Okay, so secretion is key here.
Absolutely. PAH secretion is a classic example of a TM-limited saturable secretory mechanism. It works through a transcellular pathway. First, PAH is actively taken up from the blood across the basolateral membrane into the tubule cell.
Look against its gradient.
Yes, against a significant electrochemical gradient. This uptake happens primarily via transporters called organic anion transporters OAT1 and OAT3.
OATs.
And this uptake is clutterly powered. It often involves exchanging PAH for an intracellular organic dicarboxylate, like alpha-ketoglutarate, moving out of the cell.
Okay, an exchange.
But wait, it gets more complex. The cell maintains a high intracellular concentration of IKG using another transporter on the basolateral membrane, one that co-transports sodium in along with the dicarboxylate.
So, let me trace this. The NAK pump creates the sodium gradient.
Right.
That gradient drives the uptake of the dicarboxylate.
Right.
And the outward movement of the dicarboxylate then drives the uptake of PAH.
You got it. That's tertiary active transport. It's a chain reaction ultimately powered by the NAK pump. Once inside the cell, PAH is then secreted across the apical membrane into the tubule lumen, probably via other exchangers or transporters.
That's quite a mechanism, and you said it's saturable.
Yes. Just like glucose reabsorption has a T, PAH secretion also has a T, typically around 60-80 milligrams per minute. If you give someone high enough doses of PAH, the secretory transporters become saturated.
So, like glucose, PAH also has a titration curve where its secretion can become saturated.
Precisely. If you visualize that curve, as plasma PAH concentration increases, the amount excreted initially rises very steeply, much faster than the filtered load alone would predict, because of all that active secretion.
Secretion dominates at low levels.
Exactly. But then the secretion mechanisms hit their maximum capacity, their TIM, and the rate of secretion plateaus. After this point, any further increase in PAH excretion is simply due to more PAH being filtered as the plasma concentration goes up, not because more is being secreted.
Okay.
This also means that PAH clearance, the volume of plasma cleared of PAH per minute, actually decreases as plasma PAH rises above the TIM. At very high concentrations, it approaches inulin clearance because the secreted amount becomes a smaller and smaller fraction of the total excreted amount.
Interesting contrast to glucose clearance.
It is. And this illustrates a broader principle. The same OAT transporters, or similar ones that handle PAH, also secrete a vast array of other organic anions. This includes endogenous waste products like oxalate, bile salts, but also many common drugs like penicillin, furosemide, a diuretic, and various conjugated molecules.
So understanding PAH helps understand drug excretion too.
Absolutely. And that brings us to another crucial principle, especially for drug handling. Non-ionic diffusion, where the pH of the urine really matters.
Ah, yes, you mentioned this connection before.
This is fundamental. Many drugs, and also some endogenous compounds, are weak acids or weak bases. This means they exist in equilibrium between a charged form, an ion, and an uncharged neutral form.
Okay.
The key thing is that the neutral form is usually much more lipid-soluble. It can diffuse across cell membranes far more easily, far faster than the charged form, which tends to get trapped.
Lipid-soluble crosses membranes easily. Got it.
Right. And the critical insight here is that the pH of the surrounding fluid, in this case the tubule fluid, determines the balance between the charged and uncharged forms.
How so?
Remember basic chemistry. A weak acid, HA, dissociates into H+ and its charged anion. A weak base, B, accepts an H+ to become its charged conjugation, BH+. So, if you acidify the tubule lumen, meaning lower the pH, more H, plus you shift the equilibrium for a weak acid towards its neutral HA form. More HA means more can diffuse out of the lumen back into the cells and blood. So acid urine enhances weak acid reabsorption.
Acid urine, acid reabsorbed.
Right. Now consider a weak base. If you acidify the lumen, you shift its equilibrium towards the charged BH+ form. This traps the base in the lumen as the charged escination, preventing its reabsorption and enhancing its excretion.
Acid urine, base excreted.
Exactly. You can flip it too. Alkalinizing the urine enhances weak acid excretion and weak base reabsorption.
So how does this work in a real clinical scenario, like an overdose?
Think about salicylate overdose, like with aspirin. Salicylic acid is a weak acid. If a patient overdoses, one treatment strategy is to administer sodium bicarbonate intravenously.
Why bicarbonate?
Bicarbonate makes the urine more alkaline, raises the pH. This shifts the equilibrium of salicylic acid in the tubule lumen towards its charged anionic form, salicylate ion. This charged form is less lipid-soluble, gets trapped in the lumen, and can't easily diffuse back into the body.
So it stays in the urine to be excreted.
Precisely. Alkalinizing the urine significantly enhances salicylate clearance, helping the body get rid of the drug faster. It's a life-saving intervention based directly on this principle of non-ionic diffusion.
That's a fantastic illustration. Understanding these transport mechanisms is truly fundamental to guiding clinical interventions. Okay, let's move on to phosphate. It's vital for bone, energy metabolism, buffering.
Absolutely. And a large amount, maybe around 7,000 milligrams per day, gets filtered by the glomeruli. So obviously the kidney must reabsorb most of it.
Where does that happen?
Primarily in the proximal tubule, again, it reabsorbs about 80% of the filtered phosphate. The distal tubule handles another 10% or so. Very little happens in the loop of Henle or collecting ducts.
And the mechanism in the proximal tubule.
Phosphate enters the cells from the lumen mainly by secondary active transport, using a sodium phosphate co-transporter, often called NAPI. It uses the sodium gradient similar to glucose.
Okay, another NAP plus driven process.
Yes. Now, what's interesting about phosphate's titration curve, if you compare it to glucose, is a key difference.
What's that?
With glucose, essentially none is excreted until you hit the threshold. But with phosphate, some phosphate is always excreted, even at normal, healthy plasma phosphate levels. It means the kidney's TEM for phosphate reabsorption is actually quite close to the normal filtered load. A small increase in plasma phosphate leads to a significant increase in phosphate excretion. This highlights the kidney's crucial role in tightly regulating plasma phosphate on a daily basis, something it doesn't really do for glucose in the same way.
So it's poised to get rid of excess phosphate quickly.
Exactly. Also, unlike the relatively fixed TEM for glucose, the TEM for phosphate is highly regulated. It's very sensitive to various stimuli, especially hormones.
And what's the most important hormone regulating phosphate here?
That would be parathyroid hormone, or PTH.
PTH again.
Yes, PTH is the primary hormonal regulator, and its main effect on phosphate is to inhibit its reabsorption in the proximal tubule.
Inhibits reabsorption, meaning it promotes excretion.
Correct. PTH causes phosphaturia, increased phosphate in the urine. It does this quite rapidly by triggering the removal of those NAPI co-transporters from the apical membrane of the proximal tubule cells. It basically internalizes them via endocytosis, taking them out of action.
Pulls the transporters off the membrane?
Effectively, yes. This is a critical mechanism for lowering plasma phosphate levels when they get too high. And a fascinating clinical link here. Phosphate is the main urinary buffer for acid. So conditions that increase phosphate excretion, like PTH excess or metabolic acidosis, actually help the kidney excrete more acid by providing more buffer.
Everything is so interconnected. All right, let's turn our attention to calcium, another incredibly important ion, essential for bones, muscles, nerves, countless functions.
Absolutely. And plasma calcium is tightly regulated. Only about 45% of the total calcium in plasma is in its free ionized form, CO2+, which is the biologically active form and the form that gets filtered by the kidney.
Okay, the ionized part is filter.
Right. And the kidney does an amazing job of holding onto it, reabsorbing about 99% of that filtered calcium. This reabsorption happens across multiple segments of the nephron.
Not just the proximal tubule this time.
No, it's more distributed. The proximal tubule handles the bulk, about 65%, mostly passively, kind of following along with sodium and water reabsorption.
Okay.
Then the thick ascending limb of the loop of Henle reabsorbs another significant chunk, about 25%. This involves both passive movement between cells, driven by the electrical gradient there, and also active transcellular transport that is regulated particularly by PTH.
PTH stimulates calcium reabsorption here.
Yes. In the thick ascending limb, and especially in the next segment, the distal convoluted tubule, or DCT. The DCT reabsorbs about 8% of the filtered calcium, but this is almost entirely active, transcellular transport, and it's a major regulatory site for fine-tuning calcium excretion.
The DCT is key for regulation.
It is. Calcium transport here can be adjusted independently of sodium and water transport, which is important.
So how does this transcellular calcium movement work within those DCT cells, for instance? It has to get in and then get out.
Exactly. It's a two-main-step process designed to move calcium across the cell without raising intracellular calcium levels too high, which would be toxic. First, calcium passively enters the cell from the tubule lumen down a steep electrochemical gradient. Remember, intracellular calcium is kept extremely low.
Right.
In the DCT, this entry occurs through specific epithelial calcium channels, mainly TRPV5 and TRPV6.
Okay, channels for entry. Then how does it get out the other side, into the blood? That must require energy.
It does. This basolateral extrusion is active transport. There are two main players. One is a primary active transporter, the plasma membrane C2 plus ATPase, PMCA, which uses ATP directly to pump calcium out.
TMCA.
The other is a secondary active transporter, the Na plus NASHQ2 plus exchanger, NCX, which uses the energy of the sodium gradient, sodium moving in, to push calcium out.
So both ATP-driven pump and NAB plus gradient-driven exchanger.
Correct. The PMCA seems to be the main workhorse at lower calcium levels, while the NCX kicks in more when intracellular calcium starts to rise.
And what are the key regulators controlling this whole process? You mentioned PTH.
PTH is definitely the most important hormonal regulator. It powerfully stimulates calcium reabsorption, particularly in the thick ascending limb and the DCT. It acts via receptors on the cells, triggering signaling pathways involving CAMP and PKC that ultimately increase the activity of those apical calcium channels, TRPV56, and also stimulate the basolateral extrusion mechanisms, the PMCA and NCX. More calcium gets in and more gets pumped out into the blood.
So PTH is to save calcium.
Essentially, yes. Vitamin D also plays a role, complementing PTH. It increases the expression of proteins involved in calcium transport, particularly calcium-binding proteins within the cell that help shuttle calcium across, further enhancing reabsorption in the distal nephron.
Okay, what about calcium itself? Does the level of calcium in the blood affect its own reabsorption?
Yes, it does. This is a fascinating feedback loop. High plasma calcium levels actually inhibit calcium reabsorption, especially in the thick ascending limb.
How does the kidney sense high calcium?
The cells in the thick ascending limb and other places have a special receptor on their basolateral membrane called the calcium sensing receptor, or KSR. When high levels of calcium bind to this KSFR, it triggers intracellular signaling pathways that ultimately reduce the driving force for passive paracellular calcium reabsorption and might also inhibit the transcellular pathway. So high calcium tells the kidney, okay, we have enough, let some go.
A direct feedback mechanism.
Yeah.
Makes sense.
Yeah.
And how do common diuretics impact calcium handling? We use them all the time.
They absolutely have important effects, and they differ. Loop diuretics, like furosemide, act on the thick ascending limb.
Right.
They inhibit the transporter responsible for the lumen positive voltage there. By reducing that positive charge, they decrease the driving force for passive paracellular reabsorption of both calcium and magnesium. So loop diuretics increase calcium excretion.
Useful for treating hyperkalemia then.
Exactly. They cause calciuria. Now contrast that with thiazide diuretics, which act on the distal convoluted tubule.
The DCT, where calcium regulation happens.
Right. Thiazides actually increase calcium reabsorption in the DCT.
Increase how?
They inhibit the NaCl cotransporter on the apical membrane. This leads to changes in cell membrane potential and ion gradients that ultimately enhance the driving force for calcium to enter the cell through the TRPV5 channels and subsequently be reabsorbed. So thiazides decrease calcium excretion.
Opposite effect to loop diuretics.
Exactly. That's why thiazides are sometimes used to treat conditions where you want to reduce urinary calcium, like in patients who form calcium kidney stones, or to help manage hypoparathyroidism.
Very important clinical distinctions. Finally, let's quickly discuss magnesium Mg2 plus Fer, an often overlooked but vital electrolyte.
Definitely vital and often overlooked. Most of our body's magnesium is actually inside cells or stored in bone. Plasma magnesium is tightly regulated, though, and about 60% of it is free, ionized, and filterable by the kidney.
And magnesium deficiency can be a problem.
Oh, yes. Mg2 plus depletion, often caused by GI issues like malabsorption or diarrhea, or sometimes by diuretics or certain kidney diseases, can be quite serious. It can lead to neurologic disturbances like tetany, cardiac arrhythmias, and other problems. Hypermagnesemia, too much magnesium, usually from excessive intake or severe kidney failure, is also dangerous.
So regulation is key. How much is normally excreted?
Very little. Only 5% or even less of the filtered magnesium normally appears in the urine. The kidney reabsorbs most of it.
Where's the main site for magnesium reabsorption? Is it like calcium?
It's actually quite different from calcium and most other major electrolytes. Unlike sodium, potassium, or calcium, where the proximal tubule does the heavy lifting, magnesium reabsorption occurs mainly along the thick ascending limb of the loop of Henle.
The tail again. But didn't you say loop diuretics increase Mg excretion?
Yes, precisely because the tail is the main site. About 70% of filtered magnesium is reabsorbed in the tail, predominantly through a paracellular route, meaning moving between the cells.
Okay, 70% of the tail, mostly paracellular. What about the proximal tubule?
The proximal tubule only reabsorbs about 15% of the filtered magnesium, also mostly paracellularly, driven by water reabsorption. And the DCT and collecting ducts handle maybe another 10%, so the tail is really the dominant player for magnesium.
And what drives that paracellular movement in the tail?
It's primarily driven by that lumen-positive voltage we talked about, the electrical gradient generated by the NaCl2Cl cotransporter in the tail. That positive charge in the lumen repels positive ions like Mg2+ and T2+I, pushing them between the cells towards the blood side.
Ah, the electrical push.
Exactly. And there's a key molecular player here. A specific protein that forms part of the tight junctions between tail cells, called claudin-16, also known as percellin-1, is absolutely essential for this paracellular Mg2+ and T2+ permeability.
Claudin-16.
Yes. In fact, there's a rare genetic disorder where mutations in the gene for claudin-16 cause severe renal magnesium wasting, leading to hypomagnesemia and other problems. It really highlights how crucial this specific pathway is.
Wow. And how is magnesium reabsorption regulated? Can the kidney adjust it?
It can. For instance, during magnesium depletion, the tail somehow increases its magnesium reabsorption, though the exact mechanisms aren't fully understood. There might be some transcellular transport involved too under certain conditions.
Okay. What else influences it?
Interestingly, high plasma levels of either magnesium or calcium inhibit the reabsorption of both ions in the tau.
Both inhibit both.
It's thought to happen because both Mg2+ and Cas2+ can bind to and activate that same calcium-sensing receptor, KSR, on the basolateral membrane of the tau cells. The KSR isn't perfectly specific, so high levels of itercation trigger the downstream signaling that reduces paracellular permeability and transport.
So the KSR acts like a brake for both calcium and magnesium reabsorption in the tau.
That seems to be the case. Hormonally, PTH is, again, important. It stimulates magnesium reabsorption in the tau, similar to its effect on calcium there. Other hormones like AVP, ADH, and calcitonin also seem to stimulate Mg2+ reabsorption, likely by modulating that passive paracellular pathway.
In diuretics, we mentioned loop diuretics increase Mg loss.
Yes, loop diuretics like furosemide depress that lumen-positive voltage, reducing the driving force for passive paracellular Mg2+ reabsorption, leading to significant magnesium wasting. Thiazides have less effect on magnesium, but osmotic diuretics like mannitol can also increase magnesium excretion.
Lots of factors influencing magnesium balance.
Definitely. It's a complex picture.
Wow. We've just taken quite a journey, haven't we? A real whirlwind tour through the kidney's incredible precision. From reclaiming vital glucose to carefully fine-tuning electrolytes like calcium and magnesium and, managing waste products like urea.
It really is a system of intricate checks and balances. Just amazing.
It's a testament to the body's adaptive capabilities.
It truly is. And what's remarkable, I think, is how each solute, even though we discuss them separately with their unique characteristics, really fits into this larger, interconnected network of transporters, gradients, and regulatory signals.
Yeah, nothing works in isolation.
Not at all. Understanding these specific mechanisms, how SGLT works, how PAH is secreted, how PTH affects phosphate and calcium, is truly the key to understanding so much in medicine. Diagnostics, understanding pathologies, designing treatments, it all comes back to this fundamental physiology. If we connect this to the bigger picture, it just highlights how the kidney is constantly making these tiny micro adjustments, transporter by transporter, that have these huge macro effects on our overall health and homeostasis.
So what does this all mean for you, our listener? Well, next time you consider even a simple bodily function, maybe just take a moment to remember the silent, complex choreography happening within your kidneys. It's not just about filtering, it's about maintaining this delicate, dynamic balance that keeps everything running smoothly. Maybe it makes you wonder, what other hidden systems are working tirelessly behind the scenes in your own life that deserve a deeper look?
That's a great thought. And we know this material is dense. Renal physiology can feel overwhelming, but hopefully breaking it down like this helps. You're now equipped with the core knowledge to navigate it. Remember, you are part of the Deep Dive family, and you are absolutely capable of mastering this material.
Absolutely.
Keep that curiosity alive, keep asking questions, and keep diving deep.